Hi, everyone. So I am Dr. Rama Kastury. I am an OBGYN and a medical geneticist, and I am presenting today on the topic involving prenatal testing for X and Y variations. I did an initial presentation summarizing the various tests, prenatal screening and diagnostic tests that are available when someone is pregnant. And so today's session is a follow-up presentation after that initial presentation, just addressing a few questions that some of you may have had. Okay, so first, what would you like to know? We will start with the first question that some of you had, which discusses which was asking how accurate really is NIPT. And so if you have an NIPT report that shows that there's an increased risk of a sex chromosomal abnormality, you know, what are the chances that your baby is definitely going to have a sex chromosome abnormality? Is it 50-50? Is it 20-80? So that question it's a little bit tough to answer in a straightforward, one sentence answer, but the answer is that it really depends. So the first piece of advice I would give would be to make sure and look at the report very closely. So it depends on which lab you're using, which company did the test. And so there's a few companies out there that do NIPT testing and offer cell-free DNA. And so every lab has their own different sensitivity and specificity and positive predictive value data that they usually put on the report. So I'm going to just review some of that data right now. So I'm not using any commercial names or any names of companies. I just wanted to keep this as objective as possible. So one company, is the first company that I had reviewed some of their data, had looked at the accuracy of detecting the Y chromosome. So when you're talking, because we're focusing on X and Y chromosome abnormalities and just not abnormalities, but X and Y chromosomal changes, the first thing that you want to look for that the lab is looking for when they're doing the NIPT testing is there a Y chromosome present or not? And if there is not a Y chromosome present, are there two X chromosomes basically present or not? And so, this is a large big company that does NIPT testing, and they had reported their accuracy of determining whether the Y chromosome is present or not is 99.4%, which is pretty high. They had also reported that, and here I just go over some of their data looking at trisomy 21, their sensitivity and specificity. I'm sorry, this is supposed to say specificity, but their sensitivity and specificity are above the 99th percentile, or 99%, sorry. And then for trisomy 18, about 99%. And then for trisomy 13, a little bit lower, so about 91.7% and 99.7%. But skipping to sex chromosome changes, typically across the board, the accuracy or the sensitivity, specificity, and positive predictive value tend to be a bit lower for determining or for screening pregnancies with NIPT for sex chromosomal abnormalities. For this company, they had reported that their sensitivity was 96.2 and their specificity was 99.7. So I looked at some data from a second company, also a really big company in the United States, they had done a prospective study looking at data between 2013 and 2017 and reported this data at SMFM in 2019. And so the main objective for their study was to prospectively analyze the clinical performance of their NIPT, and they had looked at fetal outcome data from women who had received high risk, so quote unquote high risk results from over 900,000 NIPT tests performed. And so one major point I did want to point out is that when you are doing NIPT testing on a population that's age 35 and older, they tend to be higher risk. So there's a slightly higher risk of chance of a sex chromosomal abnormality or aneuploidy occurring. And then, you know, it used to be thought that NIPT was more accurate or, you know, had a higher positive predictive value, sensitivity and specificity in women that were 35 and older. But now, you know, this data, this study and a lot of newer data is looking at NIPT done in women low risk or a normal risk of the average population, so 35 and younger. And so this study looked at both of women of all ages, basically, and you know, represents the positive predictive value in women of all ages. And so skipping to monosomy X, which is Turner syndrome, they had reported that their positive predictive value was 86.7. And that positive predictive value is similar for both high-risk women, who are 35 and older, and average-risk women. So just a quick little review of sensitivity and specificity. So sensitivity is the true positive rate. It looks at the proportion of those who have some condition or they're affected by a condition and they're correctly identified as having that condition based on that test. And then specificity looks at how it's the true negative rate of a negative test. And so those people who are unaffected, what's the amount of people that are unaffected that actually have a negative test, who are correctly identified as having a negative test. So just a review on that. And then this is one last study. This is looking at the cell-free DNA. It's not one study, sorry, it's a review of multiple studies looking at positive predictive value for sex chromosomal aneuploidy. And as you can see, it's the positive predictive value is much lower in detecting you know, accuracy for sex chromosome abnormalities compared to conditions like Down syndrome, trisomy 18 and 13. So we always recommend, and this, you know, takes me to the next question, but we always recommend, again, after, you know, cell-free DNA showing a high risk result or an increased risk of a sex chromosomal aneuploidy, we always recommend to follow up with diagnostic testing with CVS or amniocentesis. So the second question was actually asking, what is the risk of miscarriage with CVS and amnio? And so the national data that's, you know, kind of older data that's been reported reports the risk being of a miscarriage after getting a CVS being about 1 in 300 to 1 in 500 chance of a miscarriage. But with, you know, some centers that, you know, where they have providers that are very highly experienced and they're doing multiple CVSs and amniocenteses, that risk actually goes, you know, there is newer data that shows that it goes down to about 1 in 1,000 chance. So it, you know, the more experienced the provider is that's doing the CVS, the lower the risk. And same with amniocentesis, it's about 1 in 300 and 1 in 500,000. And with more experienced providers, it's about 1 in 1,000. And then, you know, let's say you get your CV, you do your cell-free DNA, you find out that, there's some discordant results. There's a high risk of some kind of a sex chromosomal abnormality. You do your, you meet with your MFM or your OBGYN and, you discuss, okay, what are the next steps? So usually we present to you the scenario where you can either do CVS or amniocentesis. It would be needle in the belly or, transcervically, or you always have the option of waiting and testing the baby after the baby's born. And so one of your questions, the second part to one of the questions was, what would the testing be, what testing would be available after the baby's born? Would it be cord blood sample or a blood draw? So every center is a little bit different in the way they, how they test the baby afterwards, but you can do either or. You can always do a cord blood sample. So, after your delivery, you would deliver your baby, and then there, your OBGYN would actually be obtaining a small sample of blood from the umbilical cord. And that would be sent to whichever lab, your hospital uses to send the genetic testing. And then, sometimes depending on, the delivery and the length of the cord and the situation, getting a cord blood sample sometimes, isn't, we're unable to get a good cord blood sample. And so we can always do a blood draw from the baby. Some genetic testing labs prefer a blood draw directly from the baby. And then, some places are okay with a cord blood sample. The gold standard would be to get a blood draw from the baby. I personally lean towards doing a blood draw from the baby. I know it's not fun to have to stick the baby unnecessarily, but if you want, a nice, clean, accurate, the most accurate sample that you can get from the baby, a blood draw from the baby is really the best. With the cord blood sample, sometimes, very rarely, you can have what we call maternal cell contamination, or a mix of some of the placental tissue or placental cells in that sample. And so I would definitely make sure to clarify that with your doctor if you're having that discussion, to find out which sample your institution prefers to use. Everywhere is a little different, but you can do both. And then the recurrence risk for sex chromosomal aneuploidies. This is a really great question. So it depends on what the sex chromosomal condition, abnormality or condition is. Typically, there is a low recurrence risk in conditions like Turner syndrome or triple X syndrome, or XXY, and even in some instances of like mosaicism, the recurrence risk typically in most sex chromosomal abnormalities and conditions is quite low. It doesn't follow the typical pattern of autosomal dominant or autosomal recessive inheritance, where, let's say, in a typical autosomal recessive condition, both parents are carriers, and there is maybe like a 25% chance of both of the parents passing down an abnormal copy of a gene and the baby having a condition. In most sex chromosomal abnormalities, that doesn't follow that typical inheritance pattern. And so the chance of that condition happening again is very, very, very low, but it would really depend on what the condition is and the circumstances. Okay, so thank you very much. I hope that this was helpful, and please let us know if you have any other questions. Thank you.